All right, good afternoon, everyone. I want to thank you all for attending. This month's lecture will be presented by Dr. Jules Sumpkin.
Okay, thank you. Hopefully everyone out there can hear me. What I'm going to be speaking about today is tomosynthesis-directed biopsy, which is a new alternative to stereotactic breast biopsy. I have no disclosures. So what will we be speaking about today? I'm going to talk to you a little bit about sort of the environment that we're in and where we are in the world of breast biopsy that kind of led us to tomosynthesis-directed biopsy. I'm going to compare it, both pros and cons, to the standard way we would do mammographic-directed biopsy, which would be the prone biopsy on a dedicated table. And I'm going to talk to you a little bit about the equipment that we use to do a tomosynthesis biopsy. I'm going to go through some cases and illustrate some of the advantages or disadvantages of tomosynthesis-directed biopsy. And finally, if we have time at the end, I videotaped myself doing a case, and we can just go through, I can show you the whole process beginning to end. So let's start with a definition. What is DBT, digital breast tomosynthesis biopsy? And basically, it's our ability to do a breast biopsy using tomosynthesis as our guide. The actual biopsy part, or the sampling of the tissue, is identical to the tools and the procedure that we use when we do a standard stereotactic biopsy. So why do we need it? Why can't we do stereotactic biopsy? Why do we need tomosynthesis biopsy? I mean, after all, stereo biopsy works great. We've been doing it for decades. But part of what happened was when tomosynthesis was introduced into breast imaging a number of years ago, we started realizing that we saw lesions differently, and in some instances we saw lesions that we didn't see by conventional mammography. And then we were in a bit of a conundrum, because how could we sample the lesion if it was indeterminate? And in the beginning, when we didn't have tomosynthesis biopsy, we would do maybe an MRI, we would do an ultrasound. We had no way of doing a direct biopsy by the method that we saw the lesion. And it's very analogous to what happened when we started doing breast MRI. And in the old days, we did not have a way of doing breast MRI dedicated directed biopsy. And so we did second look ultrasounds in other ways. But that was not optimal. So once tomosynthesis came about, we needed to be able to biopsy lesions that we could only see with tomosynthesis. And what ended up happening with tomosynthesis is we started seeing a lot of architectural distortions that we didn't see by conventional mammography. And those architectural distortions, in large part, are actually very significant. If you look at your most recent radiographics, you'll see that they quote a positive predictive value of 47% when you see a architectural lesion, architectural distortion lesion only detected by tomosynthesis. And on top of that, we know that prone stereotactic biopsy has limitations. What are the limitations? Well, when a patient is lying on the table, it's very difficult to sample lesions, particularly with a small breast that are close to the chest wall. And it's also very difficult to get into the axillary tail and biopsy lesions in that location. When patients have like a severe kyphosis or something like that, it's very hard for them to lay on the table, and it's hard to position the breast. And patients, similarly, patients with really limited mobility, it's very difficult to move them on the table. And in fact, the tables are relatively uncomfortable. And they're lying on those tables for 30 to 60 minutes. When we do a stereotactic biopsy at our institution, we block out 60 minutes to do that biopsy. If you identify something on a diagnostic mammogram, therefore, you know, during the day, it's almost impossible to add it on. You have to schedule the patient for a future time. And some patients just can't tolerate it. They just can't lay on that table, and that's a problem. This is a photograph of our stereotactic room. This is our prone table. This is a patient lying on the table, and the hole in the center of the table, you can see the breast protruding through it, and it's compressed, and that's the standard positioning for a prone biopsy. Now, when you have lesions that are very close to the chest wall, there are tricks that we can do. So, for instance, in this image, you can see that her arm and shoulder are pulled through that hole to allow us to try and get more posterior, closer to the chest wall on that breast. What are the advantages of tomosynthesis-directed biopsy? Well, we can see lesions better in most instances, and I'll show you multiple examples of that. Because we're not pulling the breast through a hole in a table, access to the lesion is better than on a prone table. Because of reasons of visualization and positioning, the procedure time is less, and we can identify the lesion easier. We have a larger field of view. We can find the lesion more quickly. The biopsy clip placement and post-biopsy mammogram take about the same amount of time. There are less exposures, which is both less radiation and less time. And patients seem to really tolerate this. It's relatively comfortable for them. So again, this is that image of the patient lying on the prone table, and on the right-hand side of your screen is a tomosynthesis machine. Now the machine, the device is added to equipment added to a right onto the tomosynthesis machine. So therefore, you don't need a whole room for the prone table, and you don't have to buy one of these tables, which is hundreds of thousands of dollars. It's much less expensive to buy the add-on equipment to put onto your stereotactic. So there's less capital expense. Now I'm going to show you, this is real time, of our technologist putting the device on the tomosynthesis machine. So you can see really how easy it is to do and how little time it takes. And you can do it in between doing a diagnostic patient, because it literally is under a minute to do it. So that was real time. It's on the machine and ready to go. She's just putting the compression paddle on. And that's it. Well, nothing's perfect, right? What are the disadvantages of tomosynthesis biopsy? So one of the disadvantages, if you look at it from the operational perspective in the breast center, if I'm doing a tomosynthesis biopsy, and we'll talk about the amount of time that takes, it means I can't be using that piece of equipment for screening mammograms or diagnostic mammograms. So that's a bit of a problem. But there are ways you can get around that problem. If you only have the one machine, you can batch your Tomo biopsies together certain days of the week, certain hours of the day, by creating biopsy slots within your schedule. And when a radiologist identifies a lesion that needs a tomosynthesis-directed biopsy, you can triage it and schedule it appropriately. Now, one of the problems with tomosynthesis is that it's difficult to biopsy, as you can imagine, in seeing that setup from the bottom of the breast. So for a 6 o'clock lesion, it's not so easy to do that biopsy. But what you can do is you can lie the patient on a gurney if you have the room in your center. And a lot of the biopsy chairs these days will go completely supine, put the patient in a lateral decubitus position, and do the biopsy from underneath. Typically, we don't have the room in our suite to do it, so we don't biopsy from an inferior approach. The biopsy apparatus is very close to the face of the patient, as opposed to underneath the patient in the prone table where they can't see it. So since they can see it, we have noticed that there's a slightly increased incidence of vasovagal reaction, but it's really much less than you might anticipate. Now, the literature on this is pretty scant, actually. This is a paper that was published by Dr. Christiana Kuhl's group out of Germany. It was published in Radiology in 2014. What they did was they took their baseline of prone vacuum-assisted biopsies, that's traditional stereotactic biopsies. They had 165 lesions. They timed it, and they looked at various aspects of doing the biopsy that way. And then they had 51 tomosynthesis-directed biopsies. And they evaluated factors like, was it technically successful? And in fact, they were more successful with the tomosynthesis-directed biopsy than the prone biopsy, mostly because the lesion may not have been visible by prone biopsy, or it was inaccessible by prone biopsy. And those hurdles were overcome using the tomosynthesis-directed biopsy. They were quicker. They were almost twice as quick with a tomosynthesis biopsy as a prone biopsy, actually quite quick. And the targeting time was much less, and that in large part contributed to the overall time, diminished time. The field of view we talked about a little bit. You can see more of the breast, and so finding small subtle lesions was easier. You're not triangulating as you do with a stereotactic biopsy. It's actually a real measurement of your z-axis. The sampling time of the lesion, as we talked about, because it's the exact same equipment, was the same. Fewer exposures, and I'll show you why that is. And in their study, there were no major complications, and they had vasovagal actually in both of the groups. Our group presented a abstract at the RSNA in 2014 where we did a prospective study. We looked at 400 breast biopsies, triaged to either prone biopsy or upright biopsy. And we looked at many of the same features that Dr. Kuhl did in her study. Tomosynthesis was faster, although we weren't nearly as quick as she was, and I think it was learning curve. We had 5 operators doing it. There were less exposures with tomosynthesis, and I'll show you why that is. Success rate was equivalent. Complications were equivalent. We did a pain score on these patients, and there was no statistical difference in pain between prone and upright tomo biopsy, and we didn't see any difference in clip migration between the 2 techniques. So we looked at the total procedure time, and you can see that our DVT time was pretty close to prone time, and I would say that this was really a function of learning. And I can tell you that when I do a tomosynthesis-directed biopsy these days, it's about 13 to 14 minutes, just as Dr. Kuhl's was. Now, this is an example of a tomosynthesis view of a lesion. You can see that the field of view is much larger than it is with the prone biopsy, and in addition, I can't see that lesion with the prone machine in this instance, but it's quite visible in this one. So why are there decreased exposures? Because when you do a standard, first of all, you can find, for the reason that I showed you with the field of view, you can find it without a lot of imaging just to find the lesion to start with, particularly in a large breast. But then when you do the localization, for those of you that have done stereotactic biopsy, you take the end-on view to identify the lesion, and however many that takes to find it. And then you do 2 15-degree off-angle views, which you use to triangulate the depth of the lesion. But with tomosynthesis, it's just one view. And then you do your tomosynthesis imaging, or you're scrolling through your window to find the lesion. And what we found in our study was that there were approximately 10 images per patient for prone and 7 images for upright, and that translates to both less time and to less radiation exposure. So how do we do the procedure? Well, we identify the lesion. We decide how we're going to approach it. Are we going to go from the top of the breast, the medial side, the lateral side? So that's critical in determining how you're going to do it. And typically, we're going to take the shortest distance into the breast, but not always. If something is really close to the skin, we may have to approach it from the opposite direction. So that's a judgment call when you're planning the procedure. The tech then finds the lesion based on how you told them to approach the lesion. We do the tomosynthesis and identify the target, and then you simply put your cursor on the lesion, and the coordinates will be identified. And I'll show you what that looks like. The coordinates are then sent from the workstation in the breast imaging suite to the tomosynthesis unit. The technologist moves the stage to the appropriate position. We prep the skin, instill the lidocaine, make a puncture, and place our biopsy device just as we would with a prone biopsy. We get angled views to confirm that the needle is in the appropriate position. Now, these are not angled tomosynthesis views. These are angled two-dimensional mammographic views, the same as what we do for a stereo. And we do that instead of doing another tomosynthesis with the needle in place because of artifact, and I'll show you what that looks like. We do the biopsy, we radiograph the specimen, and we place the clip as we normally would do, and then we do a tomosynthesis of the clip to see if we're at the right Z depth, and get a confirmatory mammogram. When you're doing the biopsy, this is what you see at the tech console. You're standing in the room. You get this really nice graphic demonstrating the relationship of the needle to the target. I'm going to go into that in a little more detail in a minute. You have your X, Y, and Z coordinates. You've got a number of functions on the side, on either side that you can use. We'll talk about some of those. And then each of your images is here in a thumbnail at the bottom. So there are a lot of different things you could do, but to be honest with you, there's only like a couple of these that I ever use. One is once I've calculated I've clicked on the lesion and it gives me my X, Y, and Z. I use this icon here to send it over to the workstation or over to the biopsy device. And what we do then is we have the technologist read back that I'm using a 9-gauge assisted needle. It's 13 centimeters in length, and it's got a 20 millimeter aperture because there are different sizes of needles. So we want to make sure we're all on the same page here. I may want to cancel the target. I may want to hide the graphic on the screen so I can see the target. That's what this one's for. Now this part is really cool. I like this a lot. You don't get anything like this on the prone devices, but you get this graphic that shows me that from this is the compression paddle on the skin. So from the undersurface of the skin to the beginning of the biopsy aperture, it's 10.6 centimeters. This is the 0 millimeters tells me that because of the location of this lesion, it's centered within the right smack in the middle of the biopsy aperture. And this tells me that I have 1.2 centimeters of safety between the tip of the needle and the detector plate. It's red when there's a problem. It's orange if I'm nearing some sort of a limitation. And this purple, it's safe to proceed. Now, if I want to adjust the target because when I do my confirming mammogram, I realize I need to move my needle relative to the target in the X or the Y plane, one of the ways that I can do it is is manually jogging to the lesion, and this is my preferred way of making an adjustment. Now, if you, this is the panel that's adjacent to the biopsy device. And this thing that looks kind of like the opening of a mailbox is actually a schematic of the breast. This is the nipple. The breast is always located in this way with the nipple pointing forward. So if I want to move my needle relative to the lesion anteriorly, I'm going to move this way. If I want to move it medially or laterally, I'm going to move it this way. If I want to move towards the chest wall, I'm going to move it this way. Now you can see here that we are at the lesion. We're zeroed out across the board. So if I'm going to make an adjustment, these buttons here, and there's a corresponding safety button on the back, when I push those buttons, what happens is it's going to move the needle in 5-millimeter increments. It's inside the breast, and it's going to move it at 5-millimeter increments. So in this example, if I want to move anteriorly, I'm moving from -6.8 to -7.3, and every time I push the button, it's going to move 5 millimeters. So I can retarget the lesion, so I know exactly how many millimeters I want to move it, or I can kind of eyeball it. I know that I want to move about a centimeter. That's typically the way I do it, so it's going to be 2 clicks to move it to a centimeter anteriorly. This is a kind of a new feature that they have on their software, and this dotted line here shows me as I move this bar here. If those of you who've seen tomosynthesis, this bar here tells me where I am within the breast. So in this instance, if it's like a CC view, there's an H and an F. This is towards the head, and this is towards the foot. And as I page down through the breast, because the needle comes in at an angle, you can see the distance between this dotted line and the edge of the aperture, how as I move down in the breast towards the center of the breast from the top of the breast, this distance increased. And the reason is because the needle is angled, and it's telling me, it's showing me if I'm going to hit the edge of the plastic or not when I start putting that needle in. So it's kind of a useful tool. So let's get into it a little bit. Let's start looking at some images, some cases, and I want to sort of exemplify for you what I mean when I say maybe the tomosynthesis can help us in terms of lesion visibility. There are certain type of special calcifications that tomosynthesis biopsy helps me with. Tomosynthesis can be useful in identifying vascular structures and in identifying vessels. There's a phenomenon called target plane tunnel vision that I want to talk about. I'm going to show you some challenging lesion locations and how tomosynthesis helped us. We can do localization, either standard needle localization or radioactive seed placement with tomosynthesis assistance. And some cases that are limited on a prone table, how we can potentially biopsy that patient using tomosynthesis. So the field of view issue in terms of lesion visibility is something we talked about a little bit. And there are a couple of tricks that we can use with tomosynthesis to identify a lesion. So on prone, all we would see is this translucent box here. But I may need to see the entire breast because I want to see landmarks. I want to see where I am. Do I need to move more anteriorly or medial or lateral? And this is extremely helpful. This is 2 different ways that I can do it. This icon over here is showing me that I can look at the projection images, the whole breast, in identifying where I am within the breast. Now, what the projection images are all of those low-dose images that we take to make a tomosynthesis. So this is, you can actually, when you move your cursor in a projection image, you'll just see the breast kind of rock backwards and forwards. So this is all the raw data that we use to make the tomosynthesis, but what it allows us to do is see the entire breast. Similarly, we can make a synthetic mammogram, which is a two-dimensional mammogram reconstructed from the tomosynthesis data set, and we can show it by pressing this icon. We can show the entire breast. So again, different ways of seeing the entire breast to help us locate a small subtle lesion within the breast, allowing us to see it relative to the nipple, the chest wall, and to the adjacent parenchymal landmarks. Very valuable for us. So we talked a little bit about the fact that some lesions are seen only by tomosynthesis. And this is an example of such a lesion. This is the tomosynthesis on the left, and on the right side is the two-dimensional mammogram. Now you can see that these calcifications here, which are actually not even associated with the lesion, but here on the left side, you can see this spiculated mass that on the CC view that you just cannot see on the two-dimensional mammogram. And it's a big lesion. And here it is on the 90-degree view. It's not as well seen, but I can't see it as expected on the two-dimensional view. So this would be a perfect case to do a tomosynthesis directed biopsy. Now if I go back for a second, you can see this is one of those lesions that's it's a little bit medial in the breast on the CC view, and it's at the bottom of the breast. So if I was doing a prone biopsy, I might decide I want to come from an inferior approach. But as I said, it's a little bit cumbersome to do that in the tomosynthesis world. So I decided I'm going to approach it from the lateral side. I could have approached it from the medial side as well. I put the cursor on the lesion, and the software automatically shows me that the lesion is within the center of the aperture. There's no problem. I'm not going to hit the detector plate. I do my two views. Now these are two-dimensional views, and I see my needle. And if I want, I can bring the targeting cursor down to see the relationship of my needle to the targeting cursor, which I would probably do in this instance because I can't see the lesion on the two-dimensional pair, which I anticipated. And this is what it looks like if you do a tomosynthesis when you have the needle in place. So here's the tip, right there. That's the tip. But you can see, because of the artifact, I really can't see the lesion, even though it's a tomosynthesis. So typically, we don't do this. We do what you see on the right-hand side of your screen. So we did the biopsy. We placed the clip. Here it is. And this was atypical lobular hyperplasia, atypical ductal hyperplasia, and a radial scar. And this needs to go to surgery. What about lesions that you can see only on one view? Now that's really problematic. You can do lesions that you can see on only one view on prone, but with tomosynthesis it makes it a little bit easier. So here's an example of a two-dimensional mammogram. This is the left MLO view. This is the CC view. This clip here is from a previous biopsy of a benign lesion. And you can see on the tomosynthesis in the upper part of the breast, there's an area of architectural distortion. And I can't see that on the CC view. So what might I do? Well, one thing that I could do is I could do an ultrasound and look for this architectural distortion, which we did in this instance. And we did it, and we saw something that was shadowing. It kind of in the right location. It was 1 o'clock in the left breast. It was 6 centimeters from the nipple. Seemed like it was about right. And then we put a BB on the skin and shoot a tangent mammogram. And we say, well, that looks like it's probably pretty good. because here's that architectural distortion, and here's our BB. And so I think we can do this with ultrasound. So we do the biopsy with ultrasound, and we place a clip. Now this turned out to be stromal fibrosis. And so we said, no, this is discordant. I want to show you, when we did the tomosynthesis after placing the clip, what did we see? The clip is up here, and here in the tomosynthesis is the architectural distortion down here and probably over here. So we didn't biopsy the right place. So we decided to redo the biopsy using tomosynthesis. And we identify the architectural distortion, and we chose a lateral approach because you could see it the best. This is actually at the time of the biopsy, and you can see, I'm going to go back and forth, you can see that architectural distortion right there, a little caudal anterior to that clip. And so we do the biopsy, we place the clip, and this one is the clip that we placed when we did the tomosynthesis-directed biopsy, and you can see that it's in a completely different area than the ultrasound-directed biopsy, and the pathology was radial scar, and this lesion was surgically excised. Now, there are a lot of subtle masses and asymmetries that can be very challenging by stereotactic biopsy, and this is an example. This is a 48-year-old that presents for screening, and you can see some focal asymmetry here on the medial lateral view, and probably here on the CC view. These are some optically zoomed images. And here I'll show you the tomosynthesis. And there it is right there on the MLO view. And here it is in the lateral part of the breast on the tomosynthesis. So we did an ultrasound to see if we could find it. Now, it's not surprising that we couldn't find it because of all this fatty tissue. And fatty tissue is difficult to scan with ultrasound, but we couldn't find anything. So we elected to do a tomosynthesis-directed biopsy, and here we are coming from the lateral. And there it is right there in the center, so we can easily see it. And we do the biopsy and place the clip. And this turned out to simply be a fibroadenomatoid nodule. Certain calcifications, tomosynthesis is extremely helpful for. Here's an example of a patient that's sent in to do biopsy of indeterminate calcifications. Here's the chest wall here. Here's this cluster of calcifications on a CC spot mag view. And when we go to target her, lo and behold, on the first or second slice, which is essentially in the skin, we identify these calcifications, we realize they're in the skin, and we cancel the biopsy. Certain amorphous calcifications can be really challenging to see using standard prone techniques. And you have to understand that when we do a stereo biopsy using a prone table, the imaging capacity on one of those tables, they use old CCD technology. There actually are new tomosynthesis prone tables available, but they're extremely expensive. And so what most of you have are these have this CCD imaging train, which is not very good. So amorphous calcifications, and this was a biopsy that was failed at an outside institution and was sent to us. And you see these and it's like, oh my God, how am I going to do that? You can barely see it on these magnification views. And here on the prone, it's really, really hard to see, really hard to see. And I should have probably given you the actual tomosynthesis, but here it is on the DBT, and it was definitely more visible on the DBT. And we did the biopsy, and we radiographed the specimen as we always do, and we got these amorphous calcifications. This turned out to be atypical ductal hyperplasia, and this was surgically excised. And here's our clip. So multiple clusters of calcification can be really challenging because separating them on a standard two-dimensional image can be very difficult and tricky. I want to show you an example of what can happen even with tomosynthesis. So here's an example of some indeterminate calcifications in the posterior central left breast. These are the two views, 90-degree and CC views of the breast. So we target them and we're tomoing from medial to lateral in this instance, okay? And we identify the calcium. Here it is within the box. We identify the calcium. Everybody's happy. We're going to do our biopsy. And then we check our clip. And look what happened. Here's our clip. Now this clip, and this is the CC view, okay? So this is, up at the top here is medial, and here at the bottom is lateral. So what we did was, when we were looking through from medial to lateral, we saw calcifications and we biopsied them. But actually, there are other calcifications that were superimposed more lateral. We didn't appreciate that because we really stopped when we saw the initial calcifications, which we shouldn't have. It's really important to go through all the images from medial to lateral or from top to bottom to see if there's anything that could have been superimposed on the two-dimensional view. So we ended up going back and doing another biopsy of these other calcifications, and both of them turned out to be hyalinized fibroadenoma, but equally easily one of these could have been a cancer and the other one could have been benign. Here's an example of kind of diffuse calcifications. Now, if you look at these, you see them all over the place, and you would say, oh, well, doing a stereo should be easy. There's so many. How can I possibly miss it? Actually, if you look really closely, you may see a little architectural distortion here as well. But these are the kind that are particularly vexing when you're just trying to calculate. You need a target on a stereotactic pair because you have to target the same focus of calcium on your angled views, and it can be very difficult when you see them all over the place as you do in this 90-degree magnified view. But with Tomo, you find one calcification that I want to target. This is what I want to target, and then I do my angled pair. Here's a piece of calcium right here, and here's some of the other calcium. But I know that I'm biopsying that one piece of calcium, and lo and behold, I have a decent sample, and this turned out to be ductal carcinoma in situ nuclear grade 3. Tomo can be really helpful with vessels. This is an example. A 55-year-old was recalled for calcifications in the right breast, and they wanted to do a stereotactic biopsy, and you can see these indeterminate calcifications. But when we go to do the Tomo targeting, we see calcium on both sides of a vessel. We know that's a vessel. We cancel the stereo. This is an example of a patient that we didn't do a biopsy on, but on a screening mammogram, somebody identified a little nodular density in the inferior part of the left breast. And here it is magnified, and they couldn't find it on ultrasound, and they're working it up with compression spots and so forth, and recommend actually they recommended a tomosynthesis prior to a consideration for stereotactic, and it's this area here. This is the tomosynthesis, and I'll show you when you look at it. I'm going to go through it a couple times. This is just a blood vessel. So you really wouldn't want to do a stereotactic biopsy of that. That's going to be a mess. I want to talk a little bit about target plane tunnel vision, because when you're doing tomosynthesis, you're only seeing one plane. And so you have to mentally decide what structures might I transgress getting to my lesion? And also, as I explained before, when you have multiple clusters of calcification, you have to pay attention. So this is an example of some really tough calcifications way up in the axillary tail. This is going to be a nightmare, so you don't freak out. You decide you're going to do a tomosynthesis biopsy, and here they are, and you can see them. And when I do the tomosynthesis targeting, what I see close to the skin is this vessel that directly overlies the calcium. So I can modify my approach and stay away from that vessel because I don't want through that vessel. And here we are, place a clip, and it was a successful biopsy. It turned out to be fibrocystic disease. And these posterior lesions are very, very challenging. This is an example of some calcifications way up in the axillary tail here. And we tried to do a prone biopsy, and you can see they're not very well defined, but we can see them well enough. This is the tabletop right here. And try as we may, we could never get the needle right. And we did a biopsy anyway. Turned out we didn't get calcium. Here's our clip. It's not in the right place. So we aborted to do a Tomo from an LMO approach. You can use these oblique, any variation of the mammographic positioning you can do. And we get the calcium, and it turned out to be PASH. And here's our clip. You can do a localization with the equipment. So for instance, this is an old clip. In this instance, this was a radial scar. That's the lesion that needs to come out. And we do a tomosynthesis. We put either our localization needle or a needle that we use to deploy a radioactive clip. We do our pair. We see that the tip of the needle is close to the clip. And we deploy our seed in this instance, and it works very nicely. So just to conclude, tomosynthesis-directed biopsy is really an important capability in centers doing tomosynthesis, period. So I'm at the point where I would recommend, if you're going to be doing tomosynthesis, and virtually everybody is going to be doing tomosynthesis if they're doing breast imaging, that you fold the biopsy device, which is not that expensive, into the purchase price of the unit. As I've shown you, Tomo is faster. There are less exposures, less radiation, better access to posterior lesions. These Tomo only or one view only lesions, very helpful to use tomosynthesis. Calcifications, certain types of calcifications, particularly skin and vessels, are very easily worked out with tomosynthesis. And certain patients are just much more comfortable when you're doing a biopsy with tomosynthesis. And some are frankly more comfortable lying down. Some of our handicapped patients and mentally disabled patients may be better to be done on the prone table because they don't see the biopsy devices. And finally, it can be very cost effective because you don't have a whole room and piece of equipment dedicated to doing biopsy. And even in the busiest centers, and we have a very busy center, we don't use our stereo machine all the time. So that piece of real estate within our breast center is unoccupied for a significant period of time. There are disadvantages. It does limit the use of the tomosynthesis machine. The patient sees the needle, but we haven't really found that to be a huge problem with vasovagal. As I spoke about, the inferior approach is difficult but not impossible if you want to put the patient in a decubitus position. And just a final mention on avoiding target plane vision. Look carefully through all the tomosynthesis images to make sure you're looking at the right target. So we have time. So what I'd like to show you now is a case. of me. It's a video of just me doing actually doing a tomosynthesis biopsy. It takes about 10 minutes to show. Whoops, sorry about that. So we found a patient that was kind enough to let us videotape her as we did the biopsy. This was actually one of our very early biopsies. This is her mammogram, and she had a cluster of indeterminate calcifications in the upper outer left breast. And here's the machine and the technologist. These are two of our best techs. And she's positioning the patient. Compression, just as you would have for a standard tomosynthesis or a prone biopsy. And here we are behind the console. This is those graphics I showed you. This is where we see it. Those are the acquisition of the projection images that we talked about. And here I am looking for the calcifications, and I'm scrolling through the tomosynthesis images at this point. And I'm looking, and I'm looking, and then the technologist, of course, finds them, and then I realize she's right. And so I just put my cursor. This is me going through it, looking. You can see, I hope this projects well. Those are the calcifications. We put the target on it, and I send it over to the biopsy device. The technologist is doing the readback that we talked about, X, Y, and Z. She's doing a tomosynthesis here. Now here she is putting the device on. You can see it's pretty close to the face of the patient, but she's not really that bothered by it. We tell them to look away. Just not look at the device, and most patients are really great with this. You can see it's not particularly bothering her. The technologist is, she's now bringing the needle close to the skin, and I'm just putting in the local anesthetic now. And I make a puncture the same way that I do if I'm doing a prone case. I like to put a lot of Novocaine, particularly just under the skin. It sort of keeps the bleeding down, plus that's where most of the sensation is. Now I'm dialing the device. It's been zeroed in terms of XY, and I'm dialing it in to the Z. And I'm watching this panel that shows me I'm green when I'm 0, 0, and 0. So I'm at the appropriate X, Y, and Z. So now we do our stereotactic pair that we talked about, and here these are 2D images. It shows the target icon in place, and it shows me that I'm at the appropriate position. So now I'm gonna, this is the same as doing a prone stereo. I fire the device. I was in the pre-cocked position. I fire it. And we do not routinely do post-fire imaging. And now I'm doing my biopsy, vacuum-assisted biopsy. I typically do 6 every 2 points along the clock, 2, 4, 6, 8, 10. Do 6 biopsies. And you can see this isn't hurting her at all. We always radiograph our specimen, and we radiograph it for calcification. But even when we're doing masses, we'll radiograph it, and that can be helpful sometimes because you can literally see the mass within the fatty tissue. And we got our calcifications, so I'm happy with that. And now I'm going to put the clip in. Same clips that we use if we do a prone case. So she's going to now, she removes the needle, leaving the sheath in place. So the sheath is still at the lesion. And I'm going to go ahead, and this clicks in place. and I'm just going to depress the plunger, deploy the clip. I'm going to back out the sheath a little bit just to expose viewing the clip. And then I'm going to do a tomosynthesis. And I'm going to make sure that the clip deployed. And now I can scroll through the lead, and I can see my clip, and I can actually see the Z. I can compare the Z of my clip to the Z of my target. You can see on the left-hand side of the image, it shows me the depth within the breast, and it's at 25. The target was at 29, so there's a 4-millimeter differential between the clip and the target. That's good. We hold pressure. The other nice thing is you can see we can do everything in this room, because when I do the post-clip mammogram, I'm going to do it right here with the patient sitting in this room. And you can see she was fine. We did a pain score on her. I think her pain score was like maybe 1. So we were very happy with that. So that really completes what I wanted to talk to you guys about this evening. We have a few minutes. If anybody has a question, I'd be happy to entertain questions. So I think I'm supposed to see questions in the message box, but I'm not seeing anything. So it must have been perfect. Ask our moderator here, how are we doing?
We're doing well. I don't see any questions that have come in either.
All right, Carol, it looks like that's a wrap.
Oh, there is one. I'm sorry, there's one that just came in.
Okay.
A couple, actually. Just took them a minute to type.
Okay. Now, should I see that in the chat box?
It's in the question box.
The question box. Okay. Let's see. So the first question is, how long does the procedure take? And that video that I showed you was pretty much real time. It takes me about between 13 and 16 minutes to do a case. Another question from Val Smalley. What is the cost of a tomosynthesis machine? You know, the cost is typically, I'm just going to give you a ballpark. Just to give you a frame of reference, a digital mammography machine is probably about $125,000. A tomosynthesis is going to be closer to $300,000, so considerably more. I mean, the beauty of tomosynthesis is that when we do screening tomosynthesis, the recall rate is considerably less. It's about 1/3 as much. So that's a huge, decreased false positives is huge for us. That's one of the real problems in screening mammography. And the other thing is we're finding more invasive cancers. So that's also a huge advantage. I would venture to say that the most breast imaging services around the country now are offering tomosynthesis, or are certainly thinking about doing it in the very near future. All right, well, thank you everybody for your attention. I hope you enjoyed. I hope you learned. And I wish you all the best of luck.
Thank you very much, Dr. Sumpkin. We appreciate it.
Okay, Carol, take care.